welcome to another episode of Scanning the Market. Today I'm joined by Thomas Arnold, who is a research scientist and managing editor of Rad-Access. I really enjoyed this conversation. I hope you enjoy it too. Cheers. Exactly, yeah. And like, obviously I'm not clinical, right? Or technical or, anything really. It's like, it's nice. Like, they're complex, but like, you can understand them. They have nice pictures.
Yeah,
Yeah,
yeah. A good talk should be, interpretable by a broad audience, right? You don't want it to be
yeah,
too bogged out with jargon because not everyone sitting in the conference center has the same background, right? It's a
exactly.
mix of people that are technical and clinical and,
Hmm.
commercial.
Yeah,
So a good talk should have something for everybody.
for sure. Well, I think that's a really nice place to start then, because you have a very interesting profile. Because I think you sit across science, engineering, neuroimaging, AI, and then what you do with Rad Access with just general radiology access. I think most of the people that I deal with, and most of the people who are probably listening to this, are more on the commercial or
Mhm.
clinical side of imaging. So, how, firstly, would you explain what you do?
Yeah, so I mean, I'm a scientist,
Yeah.
and I found a problem that I was interested in solving.
Hmm.
So that's increasing imaging access.
Yeah.
So I'm focused on trying to solve that in two main ways. One is developing new technologies that can
Yeah.
actually increase the volume of scans that we can do, and then the other is in trying to promote technologies
Yeah.
that increase the volumes of scans that we can do, or
Yeah.
scans that we can read. So, in my job at Subtle Medical, I'm working on trying to improve imaging acquisition,
Hmm.
making scanners more efficient, making it so you can scan more patients per day on the same hardware,
Hmm.
multiple modalities. And then with Rad Access, the mission there really is to try to promote and highlight research of people that are
Yeah.
working in similar spaces in
Hmm.
areas that I'm particularly interested in and
Yeah.
problems that I'm interested in solving.
And so that problem, was that something you've always sort of you identified early on, or did you like fall into it through like your background in the neuroscience and engineering sort of
Yeah, so
route?
this is something that I always like try to guide mentees kind of through like early trainees in science. Um, I think passion can definitely be developed over time, and sometimes every now and then you run into someone that they have that kind of background or family history or something that really gives an inciting incident for why they want to solve a particular problem.
Hmm.
Uh, that certainly wasn't the story for me. I always knew I wanted to be a scientist, um, but I didn't really have too many scientists in my life. No clinicians growing up,
Yeah.
um, so it's spent a lot of time kind of dabbling and trying out
Yeah.
different things and seeing what I liked. I worked in like 6 or 7 different labs in undergrad, and
Well,
I did everything from like fly uh, husbandry for
yeah.
ecology, like frog catching.
Yeah.
Eventually worked my way over into the computational science department, started doing shape
Yeah.
analysis, and then migrated into cognitive neuroscience. And that's how I got into imaging.
Sure.
So started doing neuroimaging and found that I liked the tools a little bit better than the questions
Yeah.
in the cognitive neuroscience domain. Kind of pivoted over into medical imaging in a more diagnostic context, and um, you know, that was back in 2014.
Well,
And since then, uh, I've gone more steadily over into the clinical imaging side.
sure. And so, we mentioned briefly that you run Rad Access, which, I guess focuses more on the people, the research, and I guess technology, sort of improving global access. What
Yeah.
made you start that?
Yeah, so during my PhD, I was fortunate to have the opportunity to collaborate with Hyperfine on doing some of
Yeah.
the early clinical validation for them.
Hmm.
Um, Prior to that, I was working on epilepsy neuroimaging pipelines, which
Yeah.
was interesting to me, but uh, when we had the opportunity to start working with a portable low-field MRI scanner,
Yeah.
that really captured my attention.
Hmm.
So that was 2019. So I think
Yeah.
we were the third site to get that device, and I could really see the potential for what that kind of technology could do
Hmm.
for global imaging.
Yeah.
And so that was kind of the initial foray into imaging access.
Yeah.
But prior to that, I'm just a very thrifty
Yeah.
person. I'm always looking to save a buck,
Sure.
and so in my mind, it made sense for us to try to leverage the technology that we have
Yeah.
available to the fullest extent, and to try to provide services at a
Yeah.
lower cost. So it also struck a chord with my personality as well.
Nice. It's, I don't know if it's random coincidence that we're speaking today. I was doom scrolling this morning,
Yeah, that's
and I saw on Twitter that today there was a startup that it's called Adialante. Sorry, I'm just reading this off my phone because it was on there. I don't know if you've seen this, but they have built a compact mobile whole body MRI prototype in 101 days, and it uses 50% less hardware. It's quieter, lighter, and no need for special infrastructure. Runs on a per scan fee model.
yeah.
I don't know if you've been following that or not, but
No, I haven't seen that, but it's going in the newsletter for sure.
there you go. There you go.
I have to take a look at that.
Yeah.
Yeah.
Pure coincidence. I guess the imaging's become a lot more mainstream, right? Um,
Yeah, I mean, there's been a lot of activity in the low field space in the last couple of years. It's a tough market, but I'm excited to see a lot of attention being drawn
yeah.
to that.
Yeah. And yeah, I mean, look, I really like Rad-Access because, it helps translate, I think, important research and innovation into, what we started talking about, right? Into something that, an everyday Joe can sort of understand
Yeah,
and follow, right? And, but even if you're a salesperson, like, you need to know what's going on in your market. I really do believe, like, you
yeah,
can't sell something unless you really understand it. And, you need to, even if you're working at GE and Siemens and the MRIs sell themselves, right? You need to know what's going on in your space because you should be looking at what's sort of you know coming up, right?
yeah,
Um, and yeah, obviously you run a newsletter, so a lot of people see in radiology, headlines about AI, new scanners, as we spoke about, portable MRI. Um, Problem is, I think it's hard to know what is genuinely meaningful sometimes. Um,
yeah.
for you, as someone who is a scientist, what makes a piece of research actually worth paying attention to?
Yeah, so for me, it kind of goes back to that same point earlier, like that it should be understandable by everyone. So
Yeah.
if the research can clearly communicate what the actual potential downstream benefit of that technology is, and
Yes.
if that benefit seems worthwhile, that's what really gets me engaged. So, um, you know, if it's a very technical paper, um, am less likely to focus on that,
Sure.
unless the technical paper can then convey what that advancement is doing in order
Mm.
to impact imaging access, right?
Yeah.
Um, Same thing with selling products, right? It's not enough to just say we have this wonderful algorithm that does really
Hmm.
good at detecting this disease. You need to be able to show that it has a downstream benefit on the
Yes.
clinical practice, right? So same thing with academic research as well. I always skew towards covering academic research that has very clear benefits to society, and it's part of the reason why I kind of over time progressed from frog research to cognitive neuroscience to clinical
Hmm.
imaging.
Yeah.
Was getting kind of a more clear, direct line between the research that I'm conducting
Yeah.
and societal benefit.
Yeah. I think it's the best way forward. It's so funny that we're talking about this. Yesterday, I did another podcast with Deep Health, and I spoke to their chief medical officer. Um, and his approach was exactly the same, almost like a holistic type, um, people centric approach.
Mhm.
And how that was Deep Health's approach, right? Is if you put the patient and the radiologist at the center of everything that you're doing, then the results sort of come around. We were sort of speaking about how a lot of companies build for software demos,
Hmm.
um, and very few build for the consumer. And it sounds
Yeah.
like, you know, I'm not well versed in research, but it sounds like the best research papers, best studies are the ones built around the end goal, as opposed to just trying to prove something works or prove an idea or a hypothesis, right?
Yeah, I mean, the whole point of being an engineer, especially, is trying to solve meaningful problems, right?
Yeah,
Um, it's it's something that's I think sometimes scientists can get bogged down in, and they'll focus a little bit more myopically on the
yeah,
technical issue,
yeah,
and lose sight of kind of the bigger picture, and it makes it difficult for them to convey their importance of their scientific findings.
yeah,
Um, Definitely in the engineering space, first and foremost, you need to make sure that you're actually solving the problem that needs to be solved, not
yeah,
just optimizing something for the sake of optimizing it.
yeah,
Um, yeah, and I think for like a company like Deep Health, I think what they're doing, right, they're acquiring and developing technologies to support, you know, the larger RadNet organization of
yeah.
reading radiologists, right, and improving their overall efficiency. So
Mhm.
it's a great alignment of incentives between Deep Health and the actual radiologists that work for the RadNet organization, right?
Definitely.
So I think that having those two kind of operate together
Yeah,
um, makes it streamlined, makes sure that Deep Health is developing and acquiring technologies that are going to benefit um, the larger organization.
sure. Well, I guess talking about benefiting larger organizations, something you've worked on a lot is low field MRI, and it's still a sort
Mhm.
of new world
Yeah.
to me. For a non-technical listener, like, what is low field MRI, and why, should people care really about what's being developed in that space?
Yeah. So, I mean, the best way to, I think, characterize low field MRI is just to compare it to conventional MRI, right? Those are our 1.5T
Yeah,
or maybe 3T magnets that you see in most clinical imaging centers. Um, Low field MRI just uses weaker magnets.
yeah,
Um, Part of the reason we use really strong magnets, though, is that they have a really high signal to noise ratio, right?
sure.
So you can collect nice images in a relatively short amount of time.
Yeah,
Um, that's always made capturing good images on low field MRI challenging
yeah,
in the past. More recently, especially with a lot of the kind of software advances that we've had in
yeah,
deep learning instruction, image enhancement, um, the quality of the images coming off low field scanners has dramatically improved,
yeah,
but also the amount of time it takes to acquire those scans has
yeah,
gone down. Um, it's the same underlying technology, more or less, that working on developing at Subtle Medical to try to enhance the efficiency of the 1.5T and 3T systems.
sure.
Um, but that technology is now making it possible for low field MRI to provide clinically relevant imaging for certain tasks. Um,
Nice.
then the main reason why that's important is that it's not entirely true, but it is somewhat true that the cost of a scanner is um, proportional to the field strength of the magnet. So,
Yeah,
a 3T is roughly twice as much as a 1.5T.
yeah,
The original 64 millitesla and other low field MRI prices were substantially lower,
sure.
right? So that can provide an entry point, especially to more rural areas
Hmm.
or low income countries,
Yeah,
to have imaging infrastructure that they can purchase at a reasonable cost and provide that service, rather than having to either send patients far away or out of
yeah,
country, or potentially just not getting scanned at all.
sure.
So it's low field MRI I view as a critical hardware step in
Hmm.
order to provide imaging access to the large swath of the world's population that currently doesn't have access to
Yeah.
MRI.
So, like, sort of reading between the lines, the trade-off isn't like simply, high field good, low field bad. I think it seems like it's more about matching the scanner to both the clinical problem, but
Yep.
more importantly, the environment. Is that sort of the best way to think about it?
Yeah, I mean, that's part of it. There's also fundamental differences in the physics of the imaging. There's
Sure.
actually some things that you can do better at low field than you can do at high
Yeah.
field, especially like air interfaces, lung imaging. So
Hmm.
there's some unique opportunities too. But by and large, from my standpoint with bread and butter clinical imaging,
Yeah.
I think that's right. It's finding the match between available resources and
Yeah.
how can we provide imaging services based on the available resources.
Sure. And so I guess the obvious challenge for me from like an outsider's perspective is if lower field MRI is, I guess, cheaper and more accessible, I
Mhm.
imagine people probably will still ask whether the image quality is good enough. How
Yeah.
do you typically answer that?
Yeah. I mean, that's I think the largest challenge for adoption in high income countries,
Yeah.
um, and I think that there has been a struggle for adoption of low field technology in high income countries, primarily for
Hmm.
that. Radiologists are really risk averse people, right? They get
Yeah.
sued.
Yeah.
So they are on the line for that diagnostic interpretation, and they want to make sure that they have the best quality image in order to make that.
Yeah.
Um, so the challenge in the US has been finding the appropriate clinical niche for
Mm.
low field MRI. And really where the technology has been successful is in doing things that you can do at low field that you can't do at high field. For instance, ICU imaging. That's where predominantly I believe that they're selling low field scanners right now.
Yes.
The other, I think successful use cases in perioperative and intraoperative imaging, right?
Yeah.
Where you have instrumentation near the patient, and you still want to get a scan, right?
Yeah.
Um, so those use cases, I think, is where you'll see,
Hmm.
earlier adoption. There's also potential for other, I think broad potential like screening applications. If you have a lower cost scan, can you
Hmm.
then do volumetric tracking for things like neurodegenerative
Yes.
diseases? Maybe now, maybe it didn't make sense to do Alzheimer's screening, with a 3T,
Yeah.
$2.5 million magnet.
Hmm.
But if you have a $200,000 scanner, does that change the calculus and make it, the cost benefit ratio
Yeah.
change a little bit?
Yeah. I feel like there probably needs to be a little bit of a mindset shift. Instead of asking is it as good as a premium MRI scanner, which of course it's not. Perhaps the question should be, is it good enough for this specific decision? Um,
Yeah,
yeah.
yeah. I mean that can be part of it, but also, I mean, I think probably prior to that, the question is what clinical benefit can we derive from this scanner that we're not
Yeah.
currently servicing with our 1.5T or 3T systems?
Sure.
Can we
Okay.
use it for, removing the cost of transport for critical care patients? Can we use it
Yeah.
for intraoperative imaging? Can we use it to maybe um, screen out, or maybe not screen out, triage some
Yeah.
of our potentially lower risk cases, like headache report? Can we
Hmm.
just do a quick low field MRI? If that's good, we can send them on their way rather than clogging up the
Yeah.
1.5T scanner with a bunch of headache cases.
Yeah.
So finding where it can fit into the current clinical workflow in
Hmm.
the U.S. healthcare system, I think is probably uh, more important than
Yeah.
trying to convince radiologists that the quality is good enough to use it for
Yes.
things that you previously used a 1.5T for.
Sure. That makes a lot of sense. And so obviously, we mentioned like hyperfine, for example, portable MRI sounds like, you know, if they get if this is gotten right, it sounds like one of those technologies that could be really transformative. However, we both know there's a lot of technologies that say they're transformative, but are quite often, I
Yeah,
think, overhyped
yeah.
a little bit. What is your honest view on that sort of balance?
Yeah, so my honest view is that I think it is a transformative technology, but the, it has a hard commercialization problem.
Sure.
For the technology um, to have its highest
Hmm.
societal impact,
Yeah.
we need to be deploying the scanner globally. right?
Yeah.
That's where I think the largest opportunity from a societal benefit is.
Hmm.
However, to make the scanners commercially viable, we need to first, sell them in the
Yeah.
U.S. and in Europe, where they can, recoup the economic costs of
Mm.
developing these devices, right? And that's a more challenging problem because the clinical benefits are a lot more obvious when you're comparing a
Yeah.
scenario where you have just a portable CT, like, you know,
Yeah.
120 miles away from you. If
Hmm.
that's your option, and your only option in the country, then obviously the benefit of low field MRI is pretty obvious to see. But
Yeah.
if you're at a major academic center and you
Yeah.
have like six different, high field magnets,
Yeah.
convincing that you need the low field scanner is a bit
Yeah.
of a harder sell, right? And you have to
Yeah.
be able to really clearly communicate what that clinical benefit is in that scenario in order to
Yeah.
make it economically viable to keep producing these scanners and get them to their highest and best use for society.
Yeah. So it's my question. What my follow up question was going to be, what the main bottleneck is, but it sounds like the it's economics at the top, and then the clinical sort of right, the evidence of comes from that, because if it's not making money or it's not economically viable, then you're not going to get the clinical evidence from that because you can't deploy it enough. And
Yeah.
then even if it's things like workflow or like validation or deployment, you can't work on those things if it's still not economically viable because you just not got enough installs.
Yeah, and I think this is something we're seeing as kind of a broader trend across the whole industry. I think that there's becoming a lot more demand for not just showing that
Yeah.
devices, algorithms, are accurate or
Yeah.
that they produce good images, but for providing quantitative evidence
Hmm.
of return on those investments, right?
Yeah.
So, I think the portable MRI companies have caught on to this and are starting to put together a lot of studies that
Yeah.
showcase not just, the accuracy of detection of strokes,
Hmm.
but what is the economic impact on a stroke
Yeah.
unit for having
Yeah.
one of these devices?
Yeah.
And similarly in the algorithm space, you're seeing that as well, right? A lot of companies are starting to put out more, workflow related or
Hmm.
um, read time related studies to try to build the evidence for why you need to actually deploy this algorithm,
Yeah.
not just take our word for it. It's going to be great. We're going to
Hmm.
detect all the strokes, right?
Yeah.
Um, if you're not really uh, if you're detecting all the same strokes that the radiologists were going to detect anyways, and you're
Yes.
not doing it any faster than
Yeah.
they were doing it, and
Yeah.
it's not reducing their cognitive workload,
Yeah.
no real benefit, right?
Yeah. Yeah. It's interesting you said that because I got a few points here. I had a really interesting chat with the CEO of a company called Xaid, and they do a lot of
Right?
research. And, yeah. And so he was talking about you can speed up something, but if you don't reduce like the cognitive workload, it doesn't
Yeah,
matter how many more patients you can get through the door, or how much more accurate it is. The product's still not going to be adopted. And although that's hard to measure cognitive workload, right? You can't tell how stressed someone is. There's sort of ways of looking at it, I suppose. And I guess the second part to what you're saying is, and it sort of brings us back to our earlier conversation on deep health, it's why they have such a massive advantage having RadNet. When we were speaking to them yesterday, they brought in C Mode, the ultrasound company, and within 3 months they had 300 deployments.
yep,
You then can validate your data really, really quickly. And so,
yep,
he was telling us about multiple different studies they did with like 500,000 patients in breast, for example, and there was like a 21% improvement of detection or something like that. That's real
yeah,
data. And
yeah,
the point is doctors, they don't want to go with a what if company, right? They want some proof. And if you can bring that data to them and say, look, we did 500,000 scans, there's a 21% improvement. The answer is simple: yes, we'll buy now. Where do we sign, right?
hmm
Um, but it's then proving that ROI, which is the third point of what you're saying. It's why companies like yourself and other companies sort of in uh, the acceleration and optimization space, right? Like, it's why they're doing so well, because the
yes,
ROI is so obvious.
yes,
Literally, all you have to do, and I'm really simplifying this, If you want to make money in radiology sales, work for one of these companies, because you go in, you say, right, we're going to speed up your scanner by 30%. You're going to get in 30% more patients. Within 3 months, you're going to recoup your money. Within 12 months, you're making this much profit.
Yep.
It's an economic sale.
Yes.
It's really all there is to it.
Yep. Yeah, I mean, it's a great point, and I mean, I think it's kind of a shift over time. I think earlier on, like reimbursement was viewed
Yeah,
as the holy grail of
yeah,
radiology AI. It's like, oh, we have a reimbursement code, right? Which is important.
yeah.
But what I love about working in the image acquisition space is
Hmm.
that the the benefit of the technology is so evident that
Yeah,
without any reimbursement code,
yeah,
adoption is so great because
yeah.
the customers naturally understand,
Hmm.
from their standpoint, how that's going to impact their workflow and their bottom
Yeah,
line.
yeah. I think there's an interesting shift happening. We're working with another company at the moment. We've worked with them for a long time, called Avatar Medical, and you should check them out. It's a really, really cool product. They take 2D images and turn them into 3D like
Yeah,
avatars where you can like navigate round. You see that the actual patient on the screen, right?
yeah,
And the idea is essentially that if you're going into, say, you've got a tumor on your brain or you need some sort of neurosurgery, your average consultation for neurosurgery is about 12 minutes, 11, 12 minutes. And so the doctor has to convey a really, really complex, scary sort of procedure in a really
yeah,
short period of time with black and white images.
yeah,
Avatar's idea is if you can bring in this product that um, simplifies it, gamifies it a little bit, makes it easier to explain with, say, your actual brain on the screen. The idea is that patient retention increases, and then the ROI is you have more patients going through the surgeon pathway, right?
yeah,
For neurosurgery, right? Like there's a study done where 89%, and this was at Northwestern in Chicago, which is like the sixth biggest neurosurgery center in the US.
yeah.
89% of their patients migrated out of network. Um, the average, and that was done with 16,000 patients, or whatever that is, right? 90% of that is high, right?
Yeah.
It's like 14,500, something like that. So, um, the average neurosurgery without all the outside care is $45,000, right?
Yeah.
So,
Huge value.
Avatar's angle is we're not saving you, and this is where I think the transition is going to happen in AI is we're not here to save you money or save you time. We're here to make you money,
Yes.
right?
Yeah.
Because you're going to pay for our license. We're going to get you 2 to 3 extra surgeries. That's our license covered. Now imagine if we get you an extra 1,000 surgeries, right?
Yeah.
You, like it's unquestionable, and so that's why I think those types of companies will do well, and companies like yours and others are doing increasingly well. You don't get $33 million worth of funding if you're not doing something right.
Right.
Um, and that's where I think the market is going to have to head to, being revenue generators instead of time savers.
Yeah, yeah, and I think a lot of that is on the onus of proving that is on the companies, right? So we
Yeah,
need to be providing evidence to our customers that shows them that the technology has that ROI, right?
yeah,
Um, those are more complicated studies than doing, like an accuracy study, right?
yeah,
But they're incredibly valuable,
yeah.
especially for um, not only making the sale, but actually quantifying, that we are improving healthcare over time.
Yes, yeah. And I guess back to where we were and about improving healthcare, I guess on more of a global scale. Rad-Access, of course, is built around imaging access, but
Mhm.
when people talk about access, I think they often think just scanner availability, but I assume it's something a little bit more bigger than that.
Yeah, I mean, absolutely. So um, if you there's like an organization called Rad-Aid
Yep.
that does a lot of wonderful work, in trying to expand global imaging access.
Hmm.
And if you talk to people from that organization, they will tell you that imaging infrastructure is a huge problem,
Hmm.
um, but training infrastructure is actually probably the
Mm,
largest problem.
yeah.
So finding qualified radiologists to read
Yeah.
scans in low-income countries is very difficult.
Yeah.
Um, and you have a brain drain problem as well, right? So
Yes.
let's say you do train somebody
Hmm.
in the country to read scans, a lot of times they'll leave, right?
Yeah.
Because they get higher compensation if they go to a high-income country.
Oh yeah.
So, I mean, that's a huge problem.
Hmm.
There's also a lot of ways that technology can help mitigate that.
Yeah.
Um, but uh, that's, I think, the other piece is, how can we provide radiology reading services, downstream of the acquisition as well,
Yeah.
that are going to help expand global imaging access. So it's not
Yeah.
just acquiring the scan. That's a start, right? You do need the imaging infrastructure there to be able to get images of that patient, but you also need somebody that can read that scan for that patient.
Yes.
Otherwise, it doesn't really do any good.
Yeah, no, I think it's a really good point because you're right. Buying a scanner doesn't automatically mean access, right? You need the staff, you need the protocols,
Yep.
the other stuff. You need service, you need reporting, you need follow up,
Yeah.
and then ultimately you need a way to act on the result. Where do you typically see these like access initiatives start to break down? Is it that brain drain and just having the resources, or is it something else?
So I think a lot of time it's underdeveloped training programs. I think like a lot of what has been done to try to mitigate this issue and kind of grow imaging capacity
Hmm.
um, is through trying to develop in-house training programs or develop partnership training programs to
Yeah.
keep expertise locally, so that you know other countries have the opportunity to
Mm.
have images interpreted in country rather than having to
Yeah.
either send patients out of country or have
Yeah.
scans out of country.
Yeah. And I don't know how much you'll know about this. Obviously, my experience is pretty limited to Europe and in the US. Are there any other sort of countries or parts of the world where I guess new imaging models are sort of moving faster than people might expect?
Yeah, I mean, there's tons of interesting imaging innovations around the world.
Yeah.
There's definitely some very interesting things that are being done in the Chinese market.
Oh, cool.
If you look at how they handle PET imaging
Hmm.
um, and radio tracer dosing,
Yeah.
um, they have massively efficient systems of um, delivering radio tracer and therefore increasing scanner throughput.
Hmm.
Um, and you also see, I think, a lot of interesting innovations in how technologies are being used
Yeah.
in other countries. So I think another great use case there is probably in tuberculosis screening.
Oh, with
Um,
Cure, they're
yeah,
they're, they're like big leaders in that, aren't they?
yeah. So, and I think that this is you know, I see a lot of potential for in the long term, AI helping with screening
Mm.
technology. That I think is a somewhat lower risk way that we can
Hmm.
start to see some fully automated imaging pipelines. I
Yeah.
think you'll probably will see in the next 5 years um, some of that starting in Europe.
Yeah.
Um, they seem to be a little bit ahead of the U.S. on that curve, but you're already seeing this being done, more globally, particularly for TB. So I think there are other areas where you see technology being leveraged in ways that's very different than what we're doing in the
Yeah.
U.S. and Europe, and we can certainly draw lessons from that, and both good and bad in how that's being deployed.
Yeah. Yeah. I mean, it's still early, isn't it? Like
Yeah.
the whole like, I'm a big fan of this whole incidental findings
Hmm.
market. Like Cure is obviously one that we mentioned. The other one that I quite like is Medimaps, who
Hmm.
do incidental findings for osteoporosis. You scan someone's shoulder, you can see osteoporosis in their spine, right? I think there's a huge market for that because yeah, if you're in an underdeveloped country, you know you might not be able to afford to go for or have the time or resources to go for three or four different types of scan. But
Yeah.
if you could have one scan that captures everything, um, I mean, then it's the only person who's not winning is the vendors, right? Ultimately, because they're having to, instead of using their equipment for four scans, they're getting it for one. So I guess that's me being skeptical and putting my tinfoil hat on. But
Yeah.
um,
Yeah, I think they're
yeah,
still doing all right, but
I think yeah,
I mean, I think that's also like, what I what I like about the kind of opportunistic screening
Hmm.
um, research field from a commercial standpoint is that it gets back to that kind of value add of patient capture
Yeah.
that you were talking about in the neurosurgical space, right?
Hmm.
So if you can go to a major health system, you know, and screen all of their scans for osteoporosis, you can then proactively reach back out to those patients,
Yeah.
bring them back in, provide them with additional care that they actually
Mm,
need.
exactly.
But you're also capturing that patient potentially before they have a major
Yeah.
problem like broken bone,
Yeah.
broken hip. But it also provides economic incentive to you as an
Yeah.
organization to
Yeah.
deploy those algorithms, right?
Yeah.
Because you're getting that patient in your
Yeah.
catchment. Right?
Yeah. I think that's the number I remember now. Deep Health, they said they took, I think it was 76% of patients from stage three, like who would have been detected at stage 3 and 4 to like stage 1 and 2,
Yeah.
a lot earlier. And yeah, that's where the ROI comes from. I guess the interesting thing is I think the adoption curve is probably a little bit uneven in AI, right? And yeah, from a research perspective, I think where is AI genuinely helping today then, outside of what we've just been discussing around those incidental findings?
Yeah. So, I mean, there's, clinical deployment always lags research, right? There's things being
Yes.
done in the research world um, that, it takes a long time to translate
Yeah.
these technologies into healthcare, right? It's an arduous path.
Yeah.
It's not for the faint of heart.
Yes.
So there certainly is, I think, a difference between um, where we're seeing clinical benefits from AI
Yeah.
today, and where we see some potential benefits from AI in the
Yeah.
future, right? Like the opportunistic screening, that's a future benefit, right?
Yeah.
There's like very limited examples of that in clinical deployment today, but I think it's an interesting area to follow and somewhere where I see you know clinical value.
Yeah.
Um, in workflows today, I think the largest opportunities that we're seeing are on acquisition
Hmm.
and reader efficiency,
Yeah.
right? That's where most of the technologies that are succeeding operate.
Yeah.
So acquisition, it's just a very easy ROI.
Yeah.
You can very clearly communicate to the customers what the
Yeah.
benefit is. Um, the reader efficiency took a little bit of time, but once some kind of transformative technologies
Yeah.
started coming out in that space that had just undeniable benefits, I
Yeah.
think that has kind of, I wouldn't say opened the floodgates, but maybe cracked the door to other companies that operate in that space and have potential benefits based on read time. And
Yeah.
as the radiology workforce kind of crisis continues to
Hmm.
become more unstable, those benefits become greater and greater,
Yeah.
right?
Yeah. You said that and of course it's pretty obvious that the clinical lags behind research. Um, a lot of exciting research, never becomes a clinical product, right?
Sure.
What separates, I guess, research that is, academically impressive from technology that can actually survive in a hospital?
Yeah, I mean, I think a lot of that probably has to do with having the right people invested in bringing it to fruition.
Yeah.
Um, I always like to tell people that are working more on the academic side, that remind them that they see like a very small sliver of
Yeah.
what it takes to actually have a clinical impact when they're developing an algorithm, right?
Yeah.
For my PhD, I developed a bunch of different algorithms that did various different clinical tasks, right?
Hmm.
I felt really good about that. I'd put my code up on GitHub,
Yeah.
and maybe somebody download it and try it for their own research study, right?
Yeah.
Um, but number of patients impacted, like
Yeah.
basically zero, right?
Yeah.
Um, it took a lot more work than what I did during my PhD to actually bring that to fruition.
Mm.
It took larger teams than
Yeah.
just one really motivated PhD student,
Yeah.
right? So uh, having the right team and the right people
Yeah.
invested in trying to
Yeah.
commercialize the technology is key. And
Yeah.
you see that with a lot of the academic institutions um, that have strong technology transfer offices. That's their major challenge is not
Yeah.
getting patents. They have patents galore
I know.
from academics. It's finding partners to take
Yeah.
over those patents and deliver on the commercialization of those patents so that they
Yeah.
can actually recoup the loss
Yeah.
of all of those legal fees.
Yeah. Well, you kind of semi-answered my next question, but it sort of leads nicely. Is what do imaging companies often, I guess, commercial imaging companies, I'll say, often misunderstand about research, and what do researchers often misunderstand about commercialization?
Oh, that's a very good question. Um, so I think the latter part is easier for me to answer because I got into
Yeah.
that in the past a little bit. Um, I mean, I think that there's just it is fortunate that many academic researchers don't know how difficult it is to commercialize an algorithm
Yeah.
because if they did, they probably wouldn't try.
Sure.
Um, and so, you know, uh, not understanding that process in a lot of ways is it's beneficial to the radiology, AI ecosystem
Yeah.
because you still have academic founders that
Yeah.
build an algorithm and say, hey, this thing's going to sell like hotcakes, like let's go for it. And
Yeah.
they slowly over time find out how difficult that process is, and
Yeah.
they have to learn so many new things in order to actually get to
Yeah.
that stage.
Hmm.
Um, so I think that that's probably that lack of understanding of
Yeah.
the quality, the regulatory, like
Mm.
the commercial strategy, marketing,
Yeah.
all of the things that make a organization function
Yeah.
is the major, kind of deficit in understanding on the academic side. Um, on the commercial side, I would say I think commercial organizations sometimes struggle
Hmm.
um, to understand whether or not a paper presented with findings
Yeah.
um, has actual clinical value,
Yeah.
or if it is just a nice study showing a high accuracy.
Yeah.
So I think that they can often get distracted in thinking, okay, this algorithm works for this purpose, right?
Yeah.
And sink in commercial resources into developing out that algorithm, that use case, only to find that when they get to the deployment stage, there's not really that much interest in the
Sure.
technology as they've built it. That's probably the other major thing that I think commercial organizations kind of miss the mark on
Yeah.
is um, is how important seamless deployment of their
Mm.
algorithms. That's the other reason why I think that a lot of the companies that have been succeeding in the radiology AI space have kind of started in the acquisition and
Hmm.
that read time space. Um, those tools are effectively zero-click tools,
Yeah. They're invisible. Yeah.
right? So,
Yeah.
if image acquisition software is operating properly, the
Hmm.
radiologist has no idea that's in place other than maybe like a, tag description on the DICOM image, right?
Yeah.
Um, that makes it seamless for the health system, but you
Yeah.
also need to make sure you're turning that image around in the right amount of time, that it's, fitting into, the scanner PACS workflow properly,
Hmm.
seamless, so that it doesn't disrupt patient care. That deployment piece is probably something that is not thought about early in the development process for a lot of radiology AI products, something
Yeah.
that the commercial organizations miss.
Yeah. Well, again, that's the interesting thing about the deep health stuff, and I keep banging on about it. It's just so fresh to mind. Is that they
Yeah.
buy their products and develop their products based around their end users.
Mhm.
And at least I know a lot of companies will claim they do this, but I mean, the success they're having is pretty obvious. They probably what they're saying is true. Um, and it seems that they can deploy in like 6 weeks, which most other companies, 10, 12 weeks, right? Okay. Yeah, no, it's interesting. I guess something that I was really interested and that I was wanting to ask you, and I think it's interesting coming from you, is if you look at the next 5 years of imaging research, like what are the areas you think the market should be watching most closely?
Yeah, so some of the areas that I think are probably going to be really hot for adoption in the next like 5 years. Um, I think that anything related to, workflow optimization, not necessarily like just like the scan acceleration, but
Hmm.
the entire workflow of
Yes.
the technologist, right? And prior to that, manual protocoling, getting rid of that, starting with automating protocoling, um, adaptive imaging. If you look at like a lot of the OEMs, they're exploring options for having adaptive imaging sessions. So
Hmm.
maybe you actually, and this has potential scan time benefits too, but you can determine whether there's pathology present in an image. Um, if there's no pathology, maybe you do an abbreviated set of scans.
Yeah.
If you detect something in the first three scans, maybe you can determine whether or not you need to add contrast or not.
Sure.
Um, so I think there's a lot of opportunities there, especially with OEMs and OEM integration.
Hmm.
Um, workflow prioritization.
Hmm.
There's actually some good success there already, but I think you'll see
Yeah.
probably it expanding into more domains.
Hmm.
We'll have instead of kind of a first in approach to work lists,
Yeah.
you'll see more ranked prioritization, especially
Sure.
for any urgent findings.
Hmm.
Um, Kind of moving further. I'm kind of moving from the beginning of the imaging pipeline and
Yeah.
moving out.
No.
Moving further down the pipeline, um, there's definitely opportunities in workflow orchestration.
Hmm.
So understanding, which images are flowing out of the scanner
Yeah.
and how to appropriately route them to downstream algorithms. I think this is something that's going to be really crucial for large
Yeah.
enterprise organizations like Deep Health, right? As they expand their offering, if you have 1,000 magnets,
Yeah.
um, how do you ensure that all of your T1 brain scans get routed to, your segmentation software,
Hmm.
right? That's a challenging problem because
Yeah.
of the heterogeneity of the data. So I think there's an opportunity there as well.
Yeah.
Um, Whether that's done at the enterprise organization level or whether it's a service
Yeah.
provided by a third party vendor, I think there's an opportunity there.
Sure.
Um, and then I think probably everyone is bullish on the report generation, report drafting.
Yes.
Um, we've seen huge adoption rates of the preliminary versions of that technology.
Hmm.
Um, it's something that I think has a transformative, clearly self-evident benefit.
Yeah.
Um, I think we'll continue to see adoption of that going forward. And then the other thing that I see kind of in the next 5 years that I mentioned earlier is I think um, potentially some of the first fully automated image interpretation pipelines for screening purposes.
Yeah.
Um, like I think uh, like NHS will probably implement something like that in the
Hmm.
next 5 years, or at least be coming close to having a go live with that. You're already seeing a lot of the double reads in Mammo
Yeah.
um, being done by AI.
Yeah.
I think you'll maybe see a fully automated pipeline that actually allows
Yeah.
us to do screening interpretation without radiologist interpretation unless it's a critical finding.
Sure. Okay. Well, look, I have two final questions for you. If we were to do this again next year,
Yeah.
what do you think we'll be talking about that feels early today and obvious by then?
Hmm. So in the next year, I suspect that probably the biggest area of development is going to be in vision language models.
Sure.
Um, we've had, that's like kind of a buzz area within
Mm-hmm.
the field, but a lot of it is still too early to solve that kind of clinical benefit problem.
I'm going to add
Interesting.
another quick question.
Yeah.
Explain vision language models.
Yeah,
So I'm
yeah.
not all
So
trained to know what it is.
yeah, these are models that are looking. And traditionally, algorithms in imaging have looked at pixel data, right? They're
Yeah.
looking at the scan and making some kind of interpretation from that.
Mm-hmm.
Um, a lot of the more recent technology that's been developed by OpenAI, Anthropic,
Mm-hmm.
all of these companies centers around vision language models. So they're um, also taking into account text information.
Sure.
So these are the mappings that you see between a paired scan and a radiology report,
Sure.
and that can allow you to both look at the image. You can maybe query something
Mm-hmm.
about the image, and it can provide a response.
Sure.
Um, Additionally, these is I think they're seeing a lot of this technology being used for the report drafting, so it can see the scan, it can read the
Yeah.
patient, why the patient was referred, and then give you an early clinical impression of that patient that a radiologist can then review, modify, and sign off on.
Yeah. Nice. Okay. My final question then is, I guess for people who want to follow the research side of imaging without spending every night reading these massive long papers, where should they be going? What should they be paying attention to?
Yeah, so I mean, I really not to
This is
self
your
plug
chance.
Rad-Access,
There you go.
but there is a high volume of literature out there.
Yeah.
So I think trying to identify um, uh, someone in the field that is either providing regular posts or a newsletter that centers around the area that you're interested in can be immensely helpful
Yeah.
in trying to screen through, and find the signal in the noise.
Yeah.
Um, Part of why I developed Rad-Access and started doing this was to kind of hold myself accountable to finally reading all those papers that are in my browser tabs, right?
Yeah.
It's a challenging problem that I think all scientists
Mm.
struggle with. But if you can find a voice that has a similar area of interest, they can do
Mm-hmm.
a lot of that work for you,
Yeah.
and also potentially save you time from having to actually, read full articles. You can get at least an impression
Yeah.
from them, and then see if it's worthwhile digging into.
Yeah.
A lot of times, you get a lot more out of that than you can get out of reading, you know, a wall of abstracts and trying to figure out which ones to select.
Yeah.
So there's a lot of good voices. Imaging Wire, on
Mm-hmm.
many, applied radiology. So
Yeah.
find one that suits you.
Mm-hmm.
Maybe Rad-Access,
There you go.
and subscribe and follow along.
Awesome. Well, look, I'm a big fan of what you're doing. I was looking forward to this conversation, but I was dreading it a little bit because I didn't know how technical we would get. I didn't know if my knowledge would quite hold up. But you've made it very, very easy to understand, and I think that's hard to do.
No, I mean, I think that's one of the beautiful things about how you've structured your podcast. It's very much an information-seeking podcast from the point of view of the host.
Mm-hmm.
So it allows, your guests to kind of tailor the conversation to the level that you're ready to discuss at. So
Yeah. Well, I
it's
appreciate that. I look forward to meeting you at Sim, get a coffee or beer or whatever you will do, and look forward to seeing your talk as well. Thank you.
Yeah, absolutely. Have a good one, Jay.
Cheers.